Thank you for joining us for conversations and updates in gastric and gastroesophageal junction cancer. This is a conversation about practice-changing expert insights to improve outcomes. And this is a discussion of first-line treatment of gastric and GE junction cancers, and we'll be discussing, leading off with adjuvant therapy, particularly in GE junction cancers. I'm Sam Klempner. I'm a GI medical oncologist at Mass General in Boston, and I'm joined by my colleagues, Dr. Yelena Janjigian and Dr. Manish Shah. So I'm going to start off just taking a step back and giving sort of an overview of these patients. I'm sure many of the viewers are quite familiar with these tumor types, but gastric and GE junction adenocarcinomas have a lot of geographic variability, with gastric cancer incidence being highest, particularly in parts of Asia and some of South America. And this is partly related to the risk factors underlying these cancers, H. pylori, some dietary things, and other things that we yet don't understand, in addition to background germline heritable cancer syndromes, such as CDH1 mutations for gastric cancer. And GE junction adenocarcinomas have primarily been a problem of the developing world, partly related to obesity and all risk factors that are associated with increased risk of chronic acid reflux, driving inflammation and ultimately increasing the risk of developing a cancer. As many of you know, most of these patients present with rather non-specific symptoms. This may be weight loss, early satiety, abdominal pain, sometimes blood in the stool in tumors that have bleeding. And then in more proximal tumors, we see more mechanical related symptoms such as difficulty swallowing, dysphagia, pain, etc. The workup is pretty straightforward. For the most part, this involves an upper endoscopy, which is usually to establish the diagnosis, and biopsies. Critical to obtain adequate tissue for biomarker testing, which we'll be discussing a lot. And then the role of staging is really to determine the burden and extent of disease to inform therapeutic approaches. More and more, this involves PET scan. CT scan is appropriate in many situations as well. It's critical in CWER3 and true gastric cancers to consider the role of a diagnostic laparoscopy. Peritoneal disease is not well seen in any of our imaging modalities. And for deeper invasive tumors, T2 or higher, it's worth a discussion about the role for staging laparoscopy. I think many of us here feel pretty strongly that this should be offered and considered for all gastric cancer patients with more invasive disease and some CWER3 tumors as well. So now that we've talked a little bit about the background risk factors and workup, I'm going to talk about a case, and then we're going to get through the broad treatment approaches. So maybe I'll turn it over to Dr. Shah to start off. Just could you broadly overview sort of the three main approaches, including neoadjuvant chemoradiation, upfront surgery, and adjuvant therapy? I don't think we're going to need to cover perioperative therapy right now.
Sure. So, yeah, it's always a challenge sometimes. Most patients with locally advanced gastric cancer, I think it's pretty well established that doing more than just surgery alone would be important. So I think one thing that I always talk about with junior faculty and trainees is what's the most appropriate workup. And I think you touched upon this a little bit. Certainly an endoscopy to establish diagnosis and a CAT scan. PET scan is standard for esophageal cancer. In gastric cancer, we had some data a while ago that it suggests that for locally advanced tumors, a PET scan can identify in 10% of patients occult metastatic disease, like a retroperitoneal lymph node that looked normal in size but was FDG avid. These would be the N3 level lymph nodes that sometimes are resected, like in places that do extensive surgery, but often would be considered early or metastatic disease. But so for patients with early stage disease, so T1 or T2 N0, we would recommend surgery up front. For patients with locally advanced non-metastatic, we typically recommend, as you had just suggested, perioperative therapy, and I think we'll talk more about that. But from Asia, there are two large studies that looked at S1 and ZLOX that demonstrate adjuvant chemotherapy as standard of care for locally advanced disease as well. There were some studies of chemoradiation for locally advanced gastric cancer, and I think in theory it makes a lot of sense to bring the therapy up front, similar to what we do for esophageal cancer. But I think it's the difference is that the stomach is a little bit lower in the abdomen, so you might have a little more toxicity, and so it's not clear that that approach is going to move forward in the United States.
Awesome, thank you. So I'm gonna set the stage and then turn it over to Dr. Janjigian. So let's talk a little bit about some of the more recent advances in adjuvant immunotherapy for esophageal and GE junction cancer. So we saw some data not that long ago about adjuvant nivolumab, which has now emerged as a standard in many of these patients. But maybe you could start by just talking a little bit about the rationale and high risk, why they chose this population, and sort of who was included in the trial.
Sure, thanks. Yeah, the challenge in our clinics in the United States, that there's variation in practice patterns in what treatments are being offered to the patient in perioperative setting. And I think to Manish's point, everyone agrees that something more than surgery needs to be done. But I think often we see patients who get treated outside of academic centers and may not have had the same perioperative approach or may have had primary surgery. And so that's historically our clinical trials in that space have struggled with accrual. And I think that's why Checkmate 577 was an important step forward, because in some ways it was a simple study design where patients could have gotten anything, chemoradiation type approach, and had surgery, and then were randomized after all said and done. So if they came in later on in their course with a disease that was completely resected, R0 resection, but had residual disease in their lymph nodes or the primary tumor, they were eligible. And even with a 2-to-1 randomization and long sort of period of accrual, the study really struggled with accrual because patients and the clinicians often don't always have agreement across different centers as to what the best approach is for those patients. In fact, increasingly we understand that the radiation can be omitted and that chemotherapy and systemic disease control is critical in those patients. And that is probably the number one question I get asked is, what if the patient did not get chemoradiation and had surgery and in adjuvant setting had residual lymph node positive disease? Can we still offer them immunotherapy if they had only, let's say, FLOT in preoperative setting? But Checkmate 577 showed that for patients who get nothing in that setting, right, that they finish chemoradiation, have surgery, and have node positive disease, as we all know, the risk of cancer recurrence is incredibly high. Most of those patients recur within a year. And so for the first time, which showed that you can impact and treat micrometastatic disease in adjuvant setting and improve at least disease-free survival, which was doubled. Progression-free survival was 2, which is the second, endpoint was improved also. We don't have overall survival data, but I think at this point with Checkmate 649 and other studies and use of immunotherapy in stage 4 setting, it'll be difficult to show. So 577 unified the population by having the treatment postoperatively for high-risk disease. It was a very important question that demonstrated the impact on micrometastatic disease in this setting.
Yeah, no, thank you very much. I think it was definitely, a step forward for sure. Maybe to boil it down to even possibly simpler terms, like Manish, when you're seeing a stage, let's say a clinical node positive GE junction cancer patient, no matter what approach we take to that patient, what would you tell them about sort of recurrence risks and survival numbers, just broad terms?
Yeah, so as was mentioned, the node positive group is a really strong indicator for recurrence. And I think that there's a 60 to 80% chance of recurrence in the first year if you remain to be node positive after preoperative chemoradiation. And so that is an important prognostic factor. Just to comment on, the chemoradiation aspect of it. I mean, as Dr. Janjigian says, there is a lot of heterogeneity in terms of what's being done. I think the CROSS study was, established that Taxol and Carbo is a standard of care, but then following that, the CLGB intergroup study suggested that 5-FU platinum may be better for adenocarcinoma, on the PET-directed approach. So I think that there is heterogeneity, and Dr. Kelly's study, the Checkmate 577, as was said, it was independent of that. And patients who had residual disease, whether it was node positive or negative, just any residual disease, they're the ones that would be able to get adjuvant nivolumab. I think that there are some ongoing studies now looking for how to manage the patients who are not resection candidates. So about 20% of patients will be unresectable for a variety of reasons. And there are several studies looking at the role of immunotherapy with chemoradiation in an unresectable population, either during, which is, I think, Keynote 975, or after chemoradiation definitive therapy, which is, I think, Skyscraper 07. So this is an important question, the role of immunotherapy in esophageal cancer in the curative setting. And I think these are, practice changing because patient survival is improved significantly.
Yeah, no, thank you. I agree. So I'm gonna, at the end of this segment, I'm gonna go real practical. So we'll take a case. Let's say a patient is treated outside of your institution. Workup was appropriate, clinical node positive, CWERT1 adenocarcinoma. Patient gets FOLFOX radiation, goes to surgery, has an R0 resection, less than a path CR. They're PD-L1 negative, HER2 negative, mismatch repair, intact. Let's say you have all the biomarkers. At your institution, are you offering this patient adjuvant IO, something else, trial? I'll start with you, Dr. Janjigian.
Yeah, so the timing of the start of therapy and when you see those patients is critical, and it's important to consider all the pros and cons. For adenocarcinoma that are PD-L1 negative, the benefit of immune checkpoint blockade, at least we know in stage 4 disease, is less than you would hope for. And what it does to micrometastatic disease is unclear, but again, Checkmate 577 data does suggest a dose-response relationship to the so inverse proportion. So the lower the PD-L1, the less the benefit. What would I do in this patient? It really depends on what they look like, how they feel, how they're eating, and how far out from adjuvant therapy. So often you come in, especially if they come in from outside, it's been more than 3 months since they had their surgery. Sometimes it's 4 months, and they're just not feeling so great. And they're hoping to get a get out of jail free card from you to tell them that they're done, even if you know that their risk of cancer recurrence is high. So the impact on micrometastatic disease is time sensitive. After a certain point, if the patient wasn't feeling well and is coming in later on, I often say, you're done. Your disease, has been treated maximally. I don't think additional therapy is going to help. If they come in and they feel well and it's still within the range for adjuvant therapy for PD-L1 negative even patient, we do offer adjuvant nivolumab, and the FDA approved it irrespective of PD-L1, and it's approved in many countries worldwide in stage 4 setting, also irrespective of PD-L1. So, then you have to decide, is treatment now or treatment later if the patient recurs, right? And in our practice, we offer it now because the recurrence obviously is a devastating event for those patients, and we would like to prevent it. The other question is, do you really need a whole year of adjuvant therapy? The answer is probably not. I mean, this is how the study was done, but that's, a very much negotiable point depending on how the patient is feeling and how much time they're willing to commit, because they've had 3 months of perioperative therapy, then they had surgery, then they had the recovery from the period. Often they're just emotionally and physically exhausted. So we do usually 6 months of therapy and then decide whether or not we can stop, and sometimes we do.
All right, Manish, in 30 seconds, what would your approach, your institution be?
Yeah, if there was a residual disease in this patient, we would offer adjuvant nivolumab. I think that Dr. Janjigian highlighted the importance of the biomarkers, which we'll get to in the next session. But I think, really the alternative is no treatment. And I think that that's hard for a lot of people who have a high risk of recurrence. So we would offer it if they were physically able and there are no contraindications.
Yeah, we've generally been offering in this situation as well. Well, thank you both for joining us, and thanks for all the viewers for joining us on this segment on adjuvant treatment of GE junction cancers. Please be sure to click on the landing page for this activity and claim your AMA, ANCC, or ACPE credit, access the supplemental slides, and see the other segments as well. Thank you.